So welcome everybody. I'm going to go ahead and pull up our hope agreements. If you're just joining us, please tell us where you're from and how you're feeling today. And I'm going to go ahead and bring up the agreements. I wasn't sharing before. I was keeping them all to myself. Okay. So now let's see. Now we can see if we get it. All right. We got a swap. Okay, look good? All right. Okay. So welcome everybody. My name is Jen Jones. I'm the founder of Sober Livers. We have some wonderful guests here tonight. Not only do we have our special guests, but we have our wonderful advisors. And Beth, we don't have an official name for you yet, so we'll just call her Beautiful Wonderful tonight. Uh, no, so Beth is going to be helping us with our whole health advisory council, of which Dr. Zhang is part of, and most of the people who have come here to talk to us before. And so we're thankful to have Beth back to help us in that area. And then we have advisor Mark and also Kelly and Nancy on the call tonight. And then we have Lindsay, who is Sober Livers Project Coordinator. And we're happy to have her. She's also our bouncer. So that's what her title is tonight. So watch out, be good. No, I'm just kidding. She's just letting people in. So let's get started with our agreements. So here's our group guidelines. Participation is encouraged, but please inform us in the chat if you prefer to listen only. Now, we encourage feedback. So we'd like you to share your opinions with people, or if you know something that you want to share about an experience you've had, but ensure that you're using I statements. For example, I had an MRI instead of an ultrasound because I had iron overload. And medical advice, remember, please, that feedback is not medical advice. Please consult your health provider before trying anything discussed here. And please inform us if you are a medical provider. We know about you, Dr. Zhang. And so basically what that means too is also if you hear something from Dr. Zhang tonight that sounds like it's something that you'd like to try yourself, definitely go back to your doctor because he doesn't know your individual case. And so that's really important. So confidentiality, ensure that you are in a private space. Please use headphones if needed, and do not share the details of the group with outside of the meeting. And please turn your cameras on. It helps foster connection and community. We are recording this speaker meeting, but one thing I want to tell you is if you've watched any of these recordings before, you'll see that anyone who talks, you don't see their face. It's just a blank screen. So you get that anonymity, even if you want to ask a question. So please ask your questions. And if you wish to remain anonymous, use your first name as your screen name, and you can keep your camera off. Please let us know, though, why you're here, what ALD stage you are, transplant status, just so we know that we have the safety and security in case somebody slips by Lindsay. I don't think it'll happen. Vaping and smoking. No vaping or smoking on camera, please. Abstinence. While abstinence is not required to attend our meetings, please join the meeting sober. And if under the influence, do not participate verbally or in chat except to contact a facilitator for support. That facilitator will be Nancy. Nancy is our chat facilitator. So she is the one, if you have a private question you'd like to ask or a question that you'd like to ask Dr. Zhang, please send that to her, or please just put that out there to the group if you feel comfortable. Politics. Sober Livers is nonpartisan. Our focus is on our shared experience with AUD, liver disease, transplants, and related health issues. And then secularity. Sober Livers is primarily secular, but welcomes discussions on spirituality or religion as part of your recovery, following those I feedback guidelines. Pictures and recordings, please do not take any pictures or do any recordings yourself in this meeting. And late entry, this is a new one, guys. We close the doors at the end of the main meeting at 60 minutes before the optional reflection time begins. So if you need support after this time, please join our buddy system, which we'll talk about a little later, but you can sign up at that URL there, which we will put in the chat later today. And we are here to learn from each other, offering compassion, empathy, and kindness. So please take what resonates with you and leave the rest. And with that, I would like to bring Mark up. He is going to introduce our speaker tonight, Dr. Zhang. And Mark, if you will, take it away, please.
Hey, thanks, Jen. Good evening, everybody. Pleasure to be here. So we are really honored to have Dr. Zhang with us, and I think my own personal opinion is that you can best get what you need from him by just having a straightforward conversation, because he's that kind of guy. But his background is that he's a clinician, a scientist, and his focus is on ALD and AUD. He's a transplant hepatologist and does clinical research. Really, his primary focus is improving care and how our outcomes happen for people that have alcohol-related liver disease, and there's plenty of us out there. He is definitely a champion of the multidisciplinary care, and having participated in that at the Beth Israel Hospital in Boston, one of the neighboring ones from where he works, I know personally that it's an awesome approach, and he's been one of the primary guys to innovate that, to really get barriers to come down with regard to how different medical disciplines deal with each other and the patient. And boy, does that help us to do our own work. His approach is really patient-centered, with an emphasis on personalized outcomes. I wish it was incomes. And really, to me, and I've been a huge advocate of this, is, we all need to kind of take as we can as much control of our own care as possible. And that's exactly what he does. And he does that with the compass point pointed clearly at understanding and translating the technical aspects of what treatment's going to be and how, everybody's going to partner in, what they're going to do and what you're going to do so that the outcome can happen. And I encourage you to ask questions about that, because it's a really cool approach. And he's an advocate for systematic change. Everything that he does really is related to systematic change, and really helping us as patients better understand how we can take control of our healthcare, when to ask questions, when we should feel empowered. And that's what he's all about. So, I mean, I'm kind of overflowing with nice things to say about him, but you'll find out yourself. And I encourage you to ask questions, and I'll just turn it over.
Okay, wonderful. Thank you so much, Mark. I really appreciate you sharing that information. And I'm so glad to see everybody here tonight. I'm so happy. I'm really excited for this because we have two really great topics we're going to talk about that I really personally think both lend themselves to reducing the stigma that we all feel. So I will just go ahead and give it to Dr. Zhang. Take it away.
Well, let me share my screen, and well, thank you, Jen and Mark. Mark, you did a very amazing job. Summarize what I am doing and what I'm planning to do in the future, and that's very impressive. But well, thanks for the nice comments on my work. But obviously, I really enjoyed what I'm doing. And again, at the end of the day, I want to help our patients, and I want to improve their quality of life, not just survive, but actually thrive. So that's the ultimate goal of my research. Let me share my screen and let's see. So are you guys seeing my full screen?
Yes.
Again, my name is Wei, and I'm a transplant hepatologist, and I see patients before and after liver transplant, and I have special interest in helping patients with alcohol-associated liver disease across a broad spectrum of alcohol-related liver disease, from early stage liver disease until cirrhosis and post liver transplant care. So, so I'm going to talk about alcohol-related liver disease, but a very important topic that I'm going to touch is actually words. It's, again, as I said, it's a very small topic, but it actually has huge impact because it can shape the care and ultimately the outcome of patients with alcohol-related liver disease. So if you look at the languages that people use, you see some of those words that probably were used in either in public or not necessarily from a doctor or nurses conversation, but maybe you may see some of the words in the clinical notes, because nowadays everybody could see their notes, right? So on the left side, and you would see some of those terms called, for example, alcoholic or alcohol abuser, addict. Those are the words that actually are really reducing somebody to just only alcohol itself, instead of a person on the right side with alcohol use disorder, which it shows that it is a person, and this person could be a parent, it could be a daughter, son, it could be a partner, it could be somebody who's working around you. So when we reduce a person to just only somebody who drinks alcohol, that is actually could really hurt. And the next one, alcoholism, alcohol abuse. This is basically indicates more of a moral failure, which is also going to hurting our patients. And we prefer to use a just alcohol use disorder, which is basically a medical term that indicates this is a disorder, this is a disease itself. And also you probably heard or see some of the other terms, for example, non-compliant, right? Non-compliant typically means, oh, this patient doesn't want to come to our appointment, or this patient doesn't take the medications, which may not be the whole picture. It could be just a patient is not able to afford a medication. A patient is not able to find a ride to come to the appointment, or a patient just feels sick that the patient couldn't come. And if we are able to use a person-first language, for example, this individual has difficulty following treatment plans, this will make patients feel really, being respected instead of being blamed for unable to do things that a doctor suggested. And another term that is frequent flyer, that typically indicates a patient who has had frequent admissions, right? But this is really also a demoralizing term that just put blames on a patient as a burden, meaning, oh, why do you come? Why do you keep on coming, right? But it's actually not because they want to come. Nobody wants to come to the emergency room and just stay there for like 7-8 hours or something, 12 hours. At MGH, actually, sometimes it may take them, it may take up to 24 to 48 hours for them to get a bed, actually, even. And instead, I think we should use a patient with repeated admissions to show the respect to our patients. So, and then regarding the liver disease part itself, and obviously we always hear and we always see newspapers about alcoholic hepatitis, alcoholic liver disease, alcoholic cirrhosis. Those are all the terms with alcoholic, which again is just labeling those people and blaming, our individuals with about their liver disease that's purely caused by alcohol, which is actually not necessarily the case. And instead, use alcohol-associated or alcohol-related terms will make our patients feel, again, more respected, and that could build trust on our providers. In the past 5 to 10 years, I think we've made a lot of progress, especially in the medical field, that we have been using less and less of those terms, but they're still there. And well, after my presentation, you could share your stories with me about your experience with some of those terms. And so the question is, well, some people may ask, well, they use the terms, but why does it matter, right? Why does it matter to you? Actually, it does shape care, as I mentioned briefly. So when we use those terms that could make patients feel that they have failed themselves, or we just label them as, addict, those patients will have a lot of shame, and they will not tell you the truth, which is called secrecy. And I could share a story about a true story of a patient that I took care of, which actually the outcome was actually pretty sad. And also, they will not come to, some of those patients will not come to the follow-up visits because they don't want to hear those terms. And also, they have a fear of judgment. Again, eventually, those patients, they don't want to come to care to manage their liver disease sometimes, or alcohol use, the alcohol drinking issues. And eventually, some of them just develop really decompensated cirrhosis before they are just too sick that they have to be admitted to the hospital. And obviously, those patients typically have a worse outcome and overall, because nobody wants to have a decompensated cirrhosis. Instead, if we use terms that show respect to our patients and treat them as a human being, a person with a lot of roles there, use, for example, person with alcohol use disorder, and this will create dignity, a trust. A patient could really trust a doctor if the doctor shows respect to our patients, and those patients could open up what they have. Let's say in some real cases, some patients may not want to tell, but if we're able to earn the trust, those individuals could just open up and tell you why, when they had their last drink, and why did they go back to drinking, and what they have tried and why that didn't work. I think that will really help us to make a better plan, and those patients will also be able to better engage in care, not only the liver disease itself, but actually probably care for the addiction or for the alcohol use disorder. And obviously, those patients have better outcome. And a recent study about a year ago showed that even if a patient has a cirrhosis, regardless of decompensated or compensated, if they're able to, for any kind of reasons or any kind of ways to stop drinking, the chance of decompensation and the chance of dying from liver disease is reduced by over 50%. So it does really, stopping drinking and how we can help our individual to stop drinking do really shape the outcome. And so let's step back and why language matters. Again, it shapes how care is delivered. It can also affect trust and engagement. And it could impact access to equitable care. And so some of the key takeaways is, we try to always use person-first language, not saying for patients, but for doctors, for providers. And we're also thinking that publics, like for example, social media, like any kind of media, newspapers, they should always use person first language to convey the information, to describe a condition. And we should respect self-identification, because I think some patients would label them as alcoholic or alcoholism. That's fine. That's fine. But we don't want to label others. We don't want to call them as those terms. We show our respect to those people if they want to use their terms. And eventually, small word changes equals to big impact on the care. And again, there are a lot of ways. There's still a long way to go, but I think we are seeing some good trend here in languages, in notes, and in hopefully, in a public space like media, to use person-first languages. And well, I'll be happy, if you have any questions or anything that you want to share your experiences and your stories.
Thank you, Dr. Zhang. Let's see if we can. Can you stop your slideshow for just a moment so we can see, so we can open up our screen here,
Sure.
and we'll see if anybody has any questions. I will stop your spotlight. Okay. Hey, everybody. All right. Does anybody have any questions for him on non-stigmatizing language?
Or share
How
your
many-
stories. Yeah.
Yeah. Any stories? I'm curious how many people use the words. Oh, go ahead. Oh, sorry. I was curious. Oh, Rob, yeah, I see your hand. Okay. You go ahead.
I had a question. How often is training for, nurses, doctors, et cetera, given on, the sensitivity or, the words, basically what you went over? Is that a common thing, becoming more common? Does it just vary by institution?
Very good question. I think that's one of the efforts that we're trying to put. Unfortunately, I don't think there are any formal training programs that across the nation, or any hospitals that actually require nurses or doctors to do such training, which is actually something that we're trying to see if we can get some fundings to support developing such CME courses so that people can take and learn how to use non-stigmatizing terms. Yes, it is a developing story, and we hope that in the next couple of years, we're going to be able to see some progress.
Thank you.
Jess has a question.
Mhm.
Jess. Hey, Jess. Where are you at?
She put in the chat that she has a question.
Okay. Jess, you want to go ahead?
You can put your question in the chat if you want.
Oh, there she is.
Can you hear me? I'm trying, like I did something to my screen. But I definitely did just kind of like want to touch on what he said, because after my relapse, my initial TI doctor, like his bedside manner was just so awful. Like, and the way that he treated me and like talked down to me, I didn't want to go back for my follow-up and hear anything he had to say, because he was nasty to me. So I just definitely want to touch and say that I do agree that, like, with the way that a provider talks to you and treats you, really can affect, what an individual, at least for me, it did, because I did not want to go back. I did not want to talk to that man. Whereas my doctor in UNC, he's like, I mean, like, I'll talk to him any day of the week, because he is with the trying to destigmatize labels and words and all that good stuff. So I just wanted to say thanks.
Well, thanks.
Congratulations, Jess, real quick. Congratulations on your 6 months.
Thank you. Super, like, it's a big milestone. I actually just ran into somebody the other day, and they had asked me, had I been to the bar? And I was like, I don't drink anymore. And their mouth just like dropped. And they were like, really, you? And I was like, yeah, me.
That's great.
So thanks for sharing your story. I think I've seen that very frequently. You know, when we blame our patients, you know, for what has caused the liver disease, you know, again, some of our patients are not willing to tell us exactly how much they drink or if they have had, you know, relapse. And some of them just don't want to come back to you know, the doctors, you know. And in contrary, you know, when you know, a doctor treats a patient, or you know, when a doctor sees a patient and talk to a patient in a respectful way, there's a very good chance that the patient will trust the doctor. And I have had a personal experience recently about a patient who, you know, was, you know, initially discharged to hospice because of liver disease with HRS or hepatorenal syndrome. That people thought that you know, she didn't want to tell the truth because of the shame, how much shame that she had. But I thought I could give her another opportunity, so I offered to see her in my clinic, and um, and because I, you know, talked to her in a very respectful way, she was able to actually tell me exactly how much she was drinking, and she's now doing amazing. She said it's doing amazingly. You know, her labs have improved greatly. You know, we're trying to see if we could get her transplant.
Good. That's awesome. That's really good. And Mark, you have a question, and then I think we should move on to our next subject. So, and we want to make sure we get time for everything here. Go ahead.
Oh, okay, great. Thank you. I'll just give you a quick question, kind of based on my own personal experience and just curious how you're handling this kind of stuff now. I did not get a transplant. I came very close, and I'm kind of like Lindsay and Jen, and you know, every day is kind of a new adventure. And I kind of feel like it would be the same thing whether or not I got a transplant or not. But my question is, one of the things that I had to learn through this whole interesting journey is there's a lot of things you have to pay attention to. So not only are you trying to get your internal things on an even keel, like your blood chemistry and all that other stuff, there's a whole emotional and psychological component to this. And one of the other things that I did not expect was the physical part of it, how quickly your body breaks down, and then what the heck are you going to do about it? So you got about a million different problems. And I was just curious, in your milieu, how do you address that?
You mean the are you referring to? So let me make sure that I understand your question. So you're referring to if somebody stops drinking and the liver gets better, but still feeling tired. Is that what you're referring to, or?
Well, no, that, you know, you're not quite at the transplant, but you're still, you know, you hit the bottom of the cliff, so you're trying to climb back up, and there's just a whole myriad of things impacting that particular journey.
Yeah, it's tough, you know, and for anybody who's in that setting, you know, especially with decompensated cirrhosis, they feel tired all the time because, again, liver is the source of energy. Okay, liver produces energy. And if we don't have a healthy liver, it's hard to really have energy. Okay, so what I suggest to do is actually, I mean, absolutely stay positive. Okay, try to exercise as much as you can, and then obviously, stay healthy and, do high protein diet, because that's the key, when you are trying to build up your muscle back, right? A lot of times people lose a lot of muscle. And when they're trying to build the muscle back, they need a lot of proteins,
Yeah, yeah. Just a quick comment while you're going through this. I'm tracking with everything. I lost about 45% of my muscle mass in my body.
Yeah.
It was a real eye-opening experience. But also, kind of, have you guys put together like any kind of, barometer or scorecard or something for a patient where they can see all the different parameters that they should be watching and working towards, so that, well, I didn't do too well on my balance this week, but I did much better on this other thing. So I'll take that as a positive kind of. And again, it gets into what we've talked about. It gets you more in the mindset of managing your own care.
Yep, I think it's absolutely a great comment. We don't really have, like structured program that actually could, be designed to, give to patients as to, okay, this is your schedule, right? This is what we suggest you to do. We don't have that. And obviously, different patients have different structures. Like some people may be very frail that they are not able to do so. So it's more of an
That's
individual.
right. And,
It's like
and it's interesting exactly about that. And we've been kind of talking about that, of how do you actually put something like that together? Because it's going to be completely individual to your unique circumstances, but yet addresses the paradigms or the issues that you're gonna be facing in a way that you can look at it as a challenge. You can look at something I got to check off today. However, get you across that puddle. You know what I'm saying?
absolutely.
Because we have, Jen and Lindsay and some of the rest of us have been kind of talking about how it's such a big part of not only when you're in the hospital thinking about that stuff, but then after you get out, it's like, okay, what do I do now?
Yeah. It's always hard to manage that. Yeah.
Yeah, and and one of the reasons why we have these support groups is for that, is to help each other try to figure out, what those things are that we need to help each other manage. Like, what do we eat, and how much should we work out, or how do we get moving, and things like that. So thanks, Mark. So can we go ahead and go into our gene discussion? I'm really excited for that. And then we can, if you guys have more questions about this, we can always ask more questions after the show. So go ahead, Dr. Zhang. Thank you.
All right. All right. You guys see the slides? Let me.
Yes.
So the next, I would like to touch a little bit about the genetics and liver health, and what are some of the myths, and what are some of the facts. Okay. So obviously, genes are inherited. Okay. So it's not something that you could change. And genes could be related to liver health, but it's actually fairly complicated. And first, so how genes could affect the risk. And when we talk about alcohol-related liver disease, there are two co-occurring conditions. One is alcohol use disorder. The other one is the liver disease component, right? And genes could affect both of them, okay? So in the addiction part, or alcohol use disorder part, some of the genes could affect how the brain feels being rewarded. And some people can easily be dependent on it and find it hard to stop. But there are people who, I think you've probably seen people who drink very heavily, but when they decide to stop, they stop right away. So they don't really have a dependence on it. And that's the gene that is actually playing a big part in this process. And some genes could also affect, how alcohol is broken down. And it is interesting that, more recently, what some of the studies found was that some of those individuals who received gastric bypass surgery, actually have much higher chance of having increased alcohol level in the blood. So they have a higher absorption and higher chance of causing liver damage. And this could also be some of the genes that is playing a big part. And how about the liver damage? Again, there are genes that could make the liver become scarred faster under some stress or under some inflammation. And this also explains why, I'm sure, sometimes people feel that is unfair, that why do I drink the same amount as the other person, and I'm the only person that is actually having liver disease, while the other person is like still like working, like functioning well. Well, my explanation is there are two explanations. One is, well, probably the genes are playing a big part in this process. Well, the other possibility is the other person who drink heavily, it doesn't mean that the other person doesn't have liver disease. It's just undetected. Okay, so sometimes when we think of that way, I think you will feel like, okay, it is not really a behavior. It's not really I decide if I want to be dependent on it. It's actually a lot of times it is the genes that are playing a big part. So some of the myths and facts. So for example, some people, some individual would think, oh, well, I get a transplant, my risk disappears. Okay, so they thought, oh, I got a transplant, my liver is doing good. Okay, I feel great. Probably should I can go back and drink a little bit, right? But actually, the genes don't go away. And ongoing care and vigilance about potential relapse is very, very important. And I'm not going to touch too much about it, but studies have shown that 30 to 40% of those patients who receive a liver transplant have at least one drink after their liver transplant. I don't know how you guys think, but the majority of the patients that I saw in our post-transplant multidisciplinary clinic called LIFT clinic, they were quite shocked that so many patients actually could go back to drinking. Well, not necessarily to a heavy drinking, but at least a drink. And the other myth is, well, if the liver disease runs in my family, there's nothing I can do. Which, in fact, well, family history increases the risk, but the lifestyle treatments and the support can actually really change the outcome. For example, obviously, eating healthy and manage, drinking, and if you have the disease, try to seek care. Those are all the ways that you could change how the liver disease goes. Okay. And what does it mean to our to patients and families? So genes are only one piece of the puzzle. Alcohol-related liver disease, alcohol use disorder, both conditions, the risks or the causes are most of the time are or we call it multifactorial, meaning not just single factor that is playing the most important role. So genes are just one piece, not the whole story. And care and choice could still make a huge difference. And as long as a patient realizes this, they seek care, they make the right choice, the outcome could be drastically different. And lastly, understanding genetics that help reduce stigma, feeling that genes play a big role in this part, not necessarily behavioral. Obviously, it is about psychology, biology, not the blame. Okay. So, well, again, please share with me any stories that you have and any questions that you have, and I'll be happy to answer.
Thanks, Dr. Zhang. I appreciate that. Genes are one of my favorite topics because it seems like every conference I go to, it has, I'm seeing a lot about genes and work being done in there. So thank you for that. Hey, Beth, you want to
Hi.
tell a
Yes.
story?
So, yeah, Dr. Zhang. So I come from a family with a bunch of hidden alcoholics. I mean, Baptists. No, I'm kidding. That was a joke, but still, it was people that hid their drinking due to the views of the church. And when I went public with my story, a lot of them had a really hard time with it. Anyway, fast forward to 2016. We know that alcohol has it can, affect our brains. The ammonia attaches to the brain cells, yada, yada, yada. Well, my uncle was diagnosed with Wernicke's disease, and he happened to have been the brewmaster for Miller Brewing Company for 35 years. However, while he was in the hospital going through detox and everything like that, they did constant blood panels on him, and his liver numbers were fine. So, I think so I guess my question is like, so as far as genetics go, is it the same disease that affected me where I drank and drank and drank and my liver failed, and he drank and drank and drank and he got Wernicke's? Is it the same disease, or is it different genes, or how does that work?
Well, even if you have the same, sometimes even if you have the same genes, the presentation could be different. Okay. And, so that's why, well, alcohol related damage, it could damage the brain. That's why, is your uncle, right? Your uncle had Wernicke's. And alcohol could damage the heart. That's why some people have heart disease called dilated cardiomyopathy from alcohol. Okay, there are people who could have pancreatitis, acute
Okay.
chronic pancreatitis from excessive drinking, right? And obviously, there are people who could have severe liver disease from drinking. Those are all different presentations, and it's everybody has, as I said, even if they're twins that have the same genes, the presentation could be different. Not to mention, you're just a relatives to our uncle, right? So the genes actually plays a big part in developing different kind of disease. But also the other important part is environment could also changes. And if somebody has underlying liver disease, for example, we call it metabolic syndrome, meaning somebody who's a little bit overweight, who has diabetes, those are all called metabolic syndrome. Then those patients have a high risk of having liver disease if they are also drinking heavily at the same time. Or even if they don't drink heavily, moderately, because of the underlying liver disease itself, underlying risk factors for liver disease, they could just work together to cause severe liver damage that could eventually result in cirrhosis, requiring liver transplantation.
Okay, I gotcha. And unfortunately, he was in a small town where they didn't know about Wernicke's and was not given the thiamine in time. So he now lives in an assisted living home and does not know who he is, from alcohol. So then 2 years later, I had to tell my family, guess what? Me now. So it was a very scary time for my family. But we were just, that's always been a question for us, is how did it manifest in such two different ways? So you've explained it great. I appreciate it.
Thank you.
Anyone else have a question about your genes, or any other question about non-stigmatizing language, or just questions that you may, oh, there we go. Nicole. Hey, Nicole. Good to see you.
Hi. I just found out recently that my transplant team, I don't know, whoever it was, I guess my surgeon, I guess, but they saved a part of my liver and they're to possibly I don't know what the parameters are, but to test my liver for Wilson's disease. And I've heard of it, but I don't know much about it. I've just had a lot of like seemingly odd reactions, autoimmune look-alike reactions to a lot of things in my life. So, what I guess my question would be, what is Wilson's disease in relation to? Is that a genetic thing and how it manifests with the liver, where the connection is?
Yeah, absolutely. So Wilson's disease is a genetic disease. It is a change of an enzyme called ATP 7B. Okay. The genes, because of the deficiency, this disease could present with mostly two different symptoms. One is something happening in the brain, and the other one is something that could happen in the liver. Some patients may present with, some of the tremors, unable to walk, because it's a disease of the copper that couldn't be excreted and just sitting in the liver or in the brain, that is causing all kinds of symptoms. So well, I know this is a group that. So my question actually is: do you also drink alcohol or at the same time? Okay, right.
Well, I had my transplant like almost 6 months ago, but yeah, I was for a few years.
Got it. Yeah. So I mean, because of, for anybody who's young, and if they don't drink that much, and we always test for potentially some other chronic liver disease. Okay. For example, if let's give another example, like if somebody has hepatitis C, and if they're at age 30s, and if they have cirrhosis, I would not say that hepatitis C is the cause of the cirrhosis, because it takes it doesn't take like 10 years, it takes 20 to 30 years to develop cirrhosis. Okay, so let's say for you, yes, some people could develop severe alcohol-related liver disease, but if you're not drinking, you will not drink as that heavily, people would suspect that there may be some other component. As I said, if you have another component of some chronic, either genetic or some other chronic liver disease risk factors, the amount of alcohol that you need to cause a permanent liver damage is actually much lower than you thought. So that's why some people would be like, oh, I don't drink that much, why do I have bad liver disease, right? Sometimes it could be the gene that is actually playing a big part in this process. Yeah, I'm glad that you got your transplant 6 months ago, and again, I think once you get a liver transplant, the disease is cured, because the liver can produce copper again, and you wouldn't need to worry about some of the potentially permanent brain damage if you do have Wilson's disease. Okay.
Right. Well, that I have had definite bouts of inability to walk, so that's probably why they were saving it potentially. So, anyway, thank you.
No problem.
Thanks,
I have a
Nicole.
question. I have a question for Jen.
Yes.
Is this meeting available to people who have to leave early, the recording?
Yes. Yeah.
Okay.
Yes. If you have to leave early, we are recording. So yes.
Okay.
We're stopping recording. We're stopping recording during the reflections period. So we will have some questions and answers that aren't there, but it'll be through the rest of this time. So, hey, Rob.
Hey, I just had a question about what are your thoughts on genetic testing? Like, should everyone, like, when you have a kid, should you get them tested at, what are your thoughts on it? I'm sure it'll obviously vary by, doctor to doctor and person to person for that matter.
Very good question. Very good question. I think in the future, the trend is that eventually everybody will be able to do a test their genes and predict the chance of developing all kinds of disease, not just necessarily liver disease, okay, but all kinds of all kinds of disease like heart disease, brain, like cancers, right? Like, I think that's gonna. It may not happen in our time, but I hope that it'll eventually happen. For genetic test for liver disease, we're still doing a lot of research. I know we have identified a couple of genes that actually could that are associated with developing liver disease. Not necessarily, alcohol-related liver disease. Actually, even fatty liver disease, like non-alcohol related. Now we call it MASLD. Okay, but we don't really know how much it plays in the development of liver disease. So even if somebody gets a genetic test, it's hard for us to predict, oh, what's your chance of developing liver disease. I don't think there's a way that we are able to do it. So I think it is a trend in the future, but it's not there yet.
Hey, Dr. Zhang, quick follow-up to that. If you do just the standard genetic mapping, if you have good data and can go back generationally, how accurate is that as compared to actual genetic testing?
So you're saying this, is that you pay like $100 or something to check your genes and stuff? Is that what you're referring to?
No, if you do through a series, the standard way of series of interviews, how many people generationally that you're immediately related to exhibit alcohol-related disorders or are alcoholics, and how many generations can you bring it back to come up with the probability that you're going to have it?
Well, that's a very good question. Obviously, the direct relative. If you have a direct relative, let's say your mom or dad, a kid, your mom or dad, direct, like first degree
This is
relative.
exactly where I wanted you to go. Okay.
Yeah. So if it's a first degree relative with this disorder, absolutely, the chance of having liver disease or alcohol use disorder is much higher. And with more, like a little bit more distant relatives, the chance of the risk is slightly lower. If that answers your question.
So, and let's go ahead with Frank's question, and then we're going to just do a couple of announcements, and then Dr. Zhang, I'd love for you to continue to answer questions if you have the time during our reflections period. Do you? Okay, wonderful.
I'll be able to answer questions. Yes.
Okay. Okay. Beautiful. Thank you. Go ahead, Frank.
Good evening, doctor, and thank you for sharing your expertise with us tonight. I'm post-transplant. Does this mean that we share our genetics with the transplant donator and our cellular? I've been reading about the cellular memory. Do we share their genetics and DNA?
Well, the genes are only, well, you got the liver from a donor, right? And the genes of the donor is different from yours, right? I think there are studies of the gene kind of, well, obviously you're taking the immunosuppressive medications, right? Because your own body will recognize those genes as foreigner that the body is trying to reject, right? But with time, the body actually recognize it. So you do, yes, you do have another copy of genes.
Yeah.
Another person, yes, you do. That's why sometimes it's hard for us to test. let's say if we want to test in blood, like if you have any genetic disorders or something, and if you got an organ from other people, you could have mixed results. So
And
yes, you do have
okay,
some copies of genes that are probably that could circulate in your blood. Yes.
and am I also to understand that our genetics and our liver structure is different than, let's say, European nationality to Asian descent or Korean, or different continents?
Mhm.
Because that's what I read. What is I guess your input on that?
So what is your
I
concern?
guess when it comes to the deciding factor, like if who's going to get what liver, it comes down to they interviewed my sister and basically my family values and things like that. When it comes down to the liver cellular structure, is that something that is different from
Different
Western
races?
European to Asian to
Yeah.
different nationalities?
No, they have not been. They're not really any significant difference regarding the race, the difference of the races, particularly in liver transplant. It doesn't matter. I think it matters
Okay,
about the blood type. Okay, and that matters because if you don't match the blood type, you're gonna be rejected right after
right.
liver
Okay.
transplant, right? So, but for races, there's not really any
It
significant.
was just a discussion that came up
Yep,
at work. And
yep.
we were all talking about my liver transplant, and somebody
Can I,
said, "Can we interchange?" And I said, "I have no idea." I
So
said, "I'm going to
can I
ask."
add to that, please? This being Minority Donor
Good.
Awareness Month, we are taught that uh, or minority donors are more compatible to the same minority. Like Black people are more compatible. That's what we're told by the OPO. So is that not true?
Mm,
Because a majority of the people on the transplant list are minorities, and we don't have enough minorities registered to be organ donors. And that's why they promote Minority Donor Awareness Month each year, which is August. So are we telling people wrong, or should we, or no? Because that's like
mm.
contradicts what they tell us.
So you mean, so let me make sure that I understand your question. So you mean most of the donors are minorities, right? But the recipients not, right? And they're promoting Minority Month for donation, or what's that? What's that? What does that mean for the Minority Month?
Donate Life has for August, they have different months. They commemorate different things on different months. In August, with Donate Life America
Uh-huh.
throughout the country, is Minority Donor Awareness Month.
I think
And
that
we have
Nancy,
signs that say it. We have minorities going into different places. Our OPOs have people who are there like special minority promoters that they send out to schools and things.
so Nancy, is the question compatibility or is the question availability?
Compatibility.
Oh,
Beth, do you know what I'm speaking of?
I know exactly what you're talking about.
Beth?
I think the Minority Awareness Month, Nancy, though, is to try to encourage more people who are minorities to become
They
donors.
tell us that minority organs are more compatible with one another. They have told us that specifically. I could even probably find it in writing somewhere. That's why I'm asking.
And we're wondering if it's true.
Yeah.
So we're told that Black to Black and Hispanic to Hispanic are more compatible. But what we're hearing you say, Dr. Zhang, is that that's not true.
Yes.
Well, I mean, it's relative. Basically, I think a white individual could still receive donors from a black person. Okay, we don't match the race.
Well,
we
what
match we
they
match
tell
the
us
blood
that
type.
too. They just
Yeah,
say
we
they're
match
more compatible with
right.
higher
So
success rates.
you know, is that well, based from our understanding, is that a significantly, a significant factor? We don't consider that as a significant factor.
So
It might be true.
environmental factors don't really impact liver compatibility.
That's right. Yeah, it's just more of a the antibody that you produce is that
Chemistry is chemistry.
yeah, is that going to cause big problems? I think, yes, the same race, when they do transplant to each other, they may produce less antibodies, but there are only a few of those major antibodies that plays the biggest roles, and some of the minor antibodies, the body is going to be able to manage it. So the answer is that it is true, but it doesn't play the most important part.
So
it may not be as important in livers. It may be more important in other organs due to the fact that some diseases are more common in different races. Like
yeah, so
sickle
Nancy's
cell
primarily around like
it
sickle
could be
cell.
lungs or hearts maybe, and not livers.
Kidney. I heard kidney before. So
kidney has a lot more, yes. So the liver is a highly tolerant organ.
That's what we love about it.
Yeah. So yes. So and typically if an individual has received a liver transplant 20 years ago, even if a patient has undetectable tacrolimus level, I don't usually do any intervention as long as the liver enzymes are normal, because as long as you have a little bit of immunosuppressant, like we know that somebody is still taking whatever the lowest dose possible, we know that the liver is not going to reject. It's not going to be rejected, especially after 10, 15, or 20 years of liver transplant. So yes, in the kidney part, I think that may play a bigger role as to the acute rejection. The lung, yes, and heart probably yes too, because they are more of a highly intolerant organs. They have high risk of having rejections. That I think they may have to test more antibodies. I cannot speak for them, but they may have to test more antibodies to fight against rejection.
Thank you. I didn't mean to open that can of worms, but
no, it's okay. It's a question I think a lot of people have, and Nancy, to your point, I mean, I think that the reason you're right. I mean, they are looking for that because of that reason, but maybe just not as much for the liver as for the other ones. So yeah, I mean, it's an important thing to understand, but I think one of the most important things is what Nancy does and what Beth does a lot of, which we really appreciate, are really promotion of organ donation. And so thank you guys for the work that you guys do, because that is what makes a difference every day. And we so appreciate you, because without you guys doing that, we would be in big doo-doo, in my opinion. Okay, I'm going to share my screen real quick, and then I promise we'll be short, and then we will get back to our questions. I hate to do this right in the middle, but I know some of you guys may need to head out, and I want to make sure that you guys see our our two different surveys, which you guys have probably seen before. But this first one is Your Voice Matters. This is for people who have alcohol-associated liver disease, have not had a transplant. This is a really important survey that we're doing. It is really all about stigma, and it really helps us to understand individuals that are affected by alcohol-associated liver disease. This is an organization that I work closely with. It's the Global NASH. It should be probably now MASH Council that is now looking at alcohol, and this will really help us understand what you guys experience with stigma, exactly what we're talking about today. It's a short survey, and so please, if you have time, please, please, please go ahead and take that survey. And then the next one is, you guys, this is the last week for this one. So this is our state of steatotic care, liver care in America. And this is with our parent organization, the Fatty Liver Foundation. They have been doing this survey for quite a few years now, but this is only the second year that we are a part of it, alcohol-associated liver disease. Once again, this is not for transplant folks. Sorry, I promise we will have quizzes coming for you or surveys coming for you soon. But please, if you have time, this is the last week to take the survey. I want to see if we could break our 10% that we got last year of 10% of people had alcohol-associated liver disease that took the survey. We know there's a lot of us, so please take the survey when you can. And Lindsay is going to put in the chat, if she hasn't already, she's going to put the links to take that survey. And with that, we can go back to our questions. And we are officially, though, in our reflections period. So thank you all. If anyone needs to leave, thank you for coming. Our next meeting is on September 14th, and that's an open discussion, and we will start that at 7 p.m. Eastern time. Okay, anyone have any more questions? I'm going to go ahead and stop so now we're stopping the recording too. So now you can ask the really juicy questions if you want.